We'll start. Sorry. I'm the holdup. I was like, I'm glad everybody's going to see the screen because it's really hard for me behind the screen. So we'll start. But anyhow, thanks. This is going to talk to you a little bit about kind of a newer technology, MEG or magnetoencephalography, long name, which is why we call it MEG, but how it can help us in surgery evaluation. So I'll just remind everybody that once we diagnose epilepsy, almost everybody starts off with medical therapy, and if that works, great. If we're tolerating medicine and not having side effects, that's the ideal situation, and we're good. Unfortunately, we have a lot of folks that doesn't work as well as we would like, and we get some degree of improvement with medicines, but seizures aren't controlled, so then we have to think about other options. And as we sit here today, there's basically four baskets, if you will, of options. So there's medicines, surgeries, devices, and dietary therapy. And depending on, epilepsy type and epilepsy syndrome, some of these may be higher on the list than others. I'm just going to focus on the highlighted one, epilepsy surgery, because this is where this technology really can help for the time being, but I realize that all the other ones are there as well for you. So I'm just going to get these out. Remember, when we treat epilepsy, I've talked about this, but our goal is kind of hopefully get you on a medicine, maybe two, and to have no seizures and to have, I would say, minimal or tolerable side effects. Ideally none, but that's hard to achieve. We have folks that unfortunately still have ongoing epilepsy. If they do, we usually kind of repeat some of their evaluation to say, what can we do? And if it turns out that surgery is a good option for them, we usually advise folks to have surgery, and the reason that we do is because surgery is our only curative option for epilepsy and has high seizure freedom rate. Our other options all treat the seizures, but they don't cure the epilepsy. And by that I mean that even if someone's seizure free on medicine, for many folks, if they back off or stop their medicines, the seizures come back. So they have an ongoing need to be on the medicine. So the disease is not cured, if you will. It's just not happening because the medicine's controlling it, which is not to say that's a bad thing. That's a good thing. But this is why if surgery is a good option, we often say that's something you should think about because it can be curative. And there obviously are folks that that's not an option for, and that's where we look at other options, which could be new medicines, devices, dietary things, lots of other things, and how do we improve their life. So let me switch to our surgery side, since that's what we're going to talk about, and just remind you.
Can I just see these? I'm so sorry.
You got to be really quick.
Sorry. Thank you.
Let's see if I can do it. There we go.
So the one that you had on with all the.
There we go.
Thank you so much. Sorry.
It's okay. All right, I'm going to get all these out so I can walk you through this. So if we think somebody from seeing them in clinic, from their outpatient testing, if they've not responded to treatment and surgery may be an option, we usually evaluate folks in kind of a logical order to make that decision. And for lack of a better term, we call it the first step, phase one. You could call it the first step if you wanted to, but we make that decision. So that usually consists of inpatient video EEG, where the patient's on camera, they have scalp electrode monitoring. Usually we re-look at our MRI. We may do different picture sequences of the brain, and we usually do baseline neuropsychology testing or cognitive testing to look at the effect of that. That's kind of the minimum that's done there. Depending on the patient, other kind of non-invasive testing may be one done. The group that I've lumped into kind of the 1A group here, as you can see, we go from kind of non-invasive to more invasive. So in an ideal world, we'd like to make a decision about surgery and be able to separate kind of our patients out from you're a good surgery candidate to you shouldn't have surgery, and then there's folks always in between, right? That you're not great, you're a maybe, you will help you, but maybe these people may be 100% helped, you might be 50% helped or something, that you should not have surgery, it won't help you at all over here. In an ideal world, we'd like to make that decision with non-invasive testing, easier for the patient to go through without having to do that. So we try and do as much as we can from that, and that's where MEG has helped us out here. And I've kind of put it between the non-invasive phase one and the invasive phase two, and that can really give us a lot of information to help make that decision. And in our experience, it's led to a lot fewer patients needing invasive monitoring because we're able to get a lot of the same information here. So let me just kind of walk you through that, and I have to answer the obvious question first, which is, oops, if I get to the next slide. Uh-oh, what we do here? Okay, let's see if I can get the computers going a little nuts here. There we go. Have to answer the obvious question first, which is how does MEG work and kind of what's it all about, so we can kind of get to how does this help you as well. This just shows you the equipment that's used with the patient, in this case a child in it, obviously it could be an adult. So there are some differences between this and other kind of brain imaging techniques in that, as you can tell, the room is very open here. The equipment's just around the head, so you're not necessarily claustrophobic like you may be in an MRI machine. And it can do infants up through adulthood, and we'll come back to kind of how it works a little bit. So how does MEG work? So what MEG is doing is our brains, think of our brains much like a computer that run on electrical activity. That electrical activity all has a magnetic field associated with it, which is why I'm sure you've been somewhere where this has happened, where someone's speaking like I am, or near a microphone, and another microphone or something with electrical activity gets too close to it, you get that horrible squawking noise because the magnetic fields are overlapping from the electrical activity. So our brains have electrical activity that creates a magnetic field. Our heads don't get stuck to anything like a magnet because the field is so weak that you don't notice it in real life, right? But that's what we're trying to pick up is. And then how does this tie into seizures? So remember, seizures are basically an electrical storm, right? It's an area in the brain that's having too much electrical activity or outside of the normal, and that's what creates the seizure. So we're picking up kind of the areas that are overly active or not acting normally, if you will, and we're looking at the seizure component, and we're taking advantage of the ability to record these very small fields. So this is if we look at a person and we say, okay, they've got an abnormality, you can see in this illustration in their brain. The electrical field has to kind of course out through the brain. You can see in various ways, but it has to get through the brain, through the spinal fluid that's the brain, through the skull, through the covering of the brain, through the skin, out to the top if we record from an electrode on the outside of the head, the normal EEG, if you will. And that can be a lot of distortion going all the way there and can dampen the signal dramatically. What MEG does is look at the magnetic field associated with that abnormality, and as you can see here, that's not distorted at all. So the MEG field will weaken with the distance, but it's not going to be distorted. And in this case, you can see a single sensor on the head that's picking up that magnetic field. So we're using very specialized equipment. It uses kind of superconducting kind of technology to record that weak field. That's the same technology that bullet trains use, for example, to kind of levitate over the train tracks and fly along at a couple 100 miles an hour. So it's the same kind of very nifty technology that has multiple uses. Right, so we have multiple sensors nowadays, and here again you see another kind of patient with one of these things. For those of you that are old enough, it almost looks like an old-fashioned hairdryer in a beauty salon. If you're not, nobody will know what that is as well. But inside of that are all these sensors, and it's just kind of this plastic on the outside. Modern ones, I'll show you kind of a picture of those. So we have all these sensors on the head. We can detect which sensors have normal brain activity, which ones we're seeing abnormal activity in. And then the key is, how do we kind of register that to the head? So we register it by using kind of these 3 coordinates, just like they do with anything else in the modern world. And unfortunately, as you're seeing on TV now with smart bombs and stuff with targeting coordinates as well, you look at these kind of 3 dimensions, so X, Y, and then Z this way, and then you can put those on the patient's own MRI as well. And if we look at the actual instrument nowadays that we use, you can see these little teeny sensors. Each one is basically about 1 inch. Most of our modern systems have several hundred of those, so they cover the whole head. So we're getting several hundred sensors as opposed to like scalp EEG that may just be 20 or so. And we can look at every point in the brain at the same time with that. And then we can superimpose it using those same coordinates on top of an MRI. So we talk about MEG, and I'll show you pictures, and you'll see they're all superimposed on the MRI. We tend to use that term when we do that rather than say magnetic source imaging, because people know MEG, know that that's the picture kind of on the brain, if you will. All right, so what are the advantages, and I'll just scroll these out kind of here, of MEG. So one, there's no, it's non-invasive. You're just laying there, it's recording brain activity. There's no radiation from it. It's recording from you. It's not subjecting you to a field like MRI. It's not giving you radiation like CT or regular X-rays. So it's totally safe from that standpoint. It's painless. Since there's nothing like that, you can repeat it as often as you would like within reason. You can only go to the hospital so many times, I guess, but it's repeatable because of that. So if you go and the test is non-informative, or you need to do part of it and then another part another day, you can do that as well. We talked about it records these very small signals, but it also records them in real time. So I'll show you examples of this, but if we test someone for speech function or motor function, it's recording that in real time as it's happening in the brain. You can actually track those signals through the brain to look at normal pathways as well. And it has very high resolution. So when we put it on top of the MRI, we can get down to the equivalent of like a 1/16 of an inch or so. So we can be very precise with where things are coming from as well. It does require a special kind of facility for the equipment. So if you start off on the far right of the slide, that's the actual kind of MEG machine, if you will, and in this case, the bed for the patient to lay down while they're getting it. And there you can see the head goes inside there. In the middle, it shows the room that this is contained in. It has this bank vault looking like door. On it, it's a specially built room because it has to shield the patient from the magnetic field that's around all of us now from the earth, because the magnetic field from your brain is much smaller, and also just from outside other magnetic fields that we all don't think about that are there every day around us. So we can just record from the patient. So they are in this room, but as you can see, and it's a reasonable sized room. It's like a college dorm size, yeah, it's about right, college dorm. Thinking of my daughter's college dorm, it's probably about that big. And then outside is this other room that you see to your left where the patient can be monitored, so you can see the brain activity. We have cameras, you can see the patient, you can talk to the patient with a microphone as well. And if we need to do sedation, because you have to be still for this, and the person can't be still because of their age, because they just have trouble being still, you can do sedation and monitor from outside as well. All right, so how does it help when we look at surgery? In my mind, there's two basic ways. It can help us figure out where the seizures are coming from, which is the epilepsy onset. But it also can help us figure out where are other important brain functions that we need to not mess with, if you will. So obviously we don't want to do surgery over someone's language area, because it's not good if you can't talk after surgery. We don't want to do it over their motor areas. It's not good if you can't move, or vision. If you can't see off to the side, that's not usually good either. So we try and like to know where those areas are. So what the MEG is going to do, remember we have a couple hundred sensors, so what I'm showing you here is just a limited sample, but with the MEG, some of the channels on top and the regular EEG on the bottom, we can identify abnormalities on the MEG as we've highlighted there. We can look at kind of the dipole associated with that, and then put that on top of the person's MRI, which you see on your right side of the slide. So in this case, this person has a structural abnormality that you see that's kind of there around the yellow triangles. Let's see, do I have a pointer? Oh, I do. Right in here. You can see the yellow kind of triangle dipoles around that. So we could say, you know what, this person has a structural abnormality in their brain. Our MEG dipoles are basically on both sides of that, kind of the top and bottom side of it. So this person, if we want to get them seizure free with surgery, would need to have this completely removed if that can be done safely. So it's very helpful in kind of saying, gosh, this has probably answered the question about where the seizures are coming from. Now the only question is going to be, can it be done safely? But it would maybe avoid this person needing invasive monitoring to answer that question of knowing where it is. If someone's had prior surgery, in this case someone had a prior tumor, and you can see the big black hole here, where they had their prior tumor taken out. They had seizures before that. They did better after getting the tumor out, but then started still having some seizures. This is always our challenge because this is black because it's filled in with fluid now, and when we record EEG from outside the head, when that electrical signal goes through brain to get to the outside of the head here compared to going through fluid, it's a very different kind of a signal that we record. So again, Meg is able to record without that being influenced. And what we saw, and maybe if you look over here, you can see that on the temporal lobe that was left just above that, we saw clear abnormalities, but also some separate ones on the back edge too. So we knew for this patient to have successful surgery and to get rid of their seizures that we needed to get rid of kind of the top edge, if you will, of the prior resection and kind of this back edge here as well too. And in our hands, we thought we could do that without any need for invasive monitoring in this patient, that we had what we needed to do to go to surgery as well. All right, Meg can also sometimes help you in making a decision to go the other way, which is sometimes not what families want to hear, but that maybe we shouldn't do surgery. So this is someone that had multiple dipoles on Meg. They had multiple brain lesions because of their disease, and they had a prominent one, as you can see here, on the back on the left. They also had in the occipital lobe. They had one slightly anterior here in the temporal lobe. Oops. Sorry. Touchy pointer here. And then if I find it here, they had a separate one. Where am I missing the color? And I'm missing the color here. Where the heck is it? Oh, parietal one on the other side, which is supposed to be a purple one, and hopefully it looks purple to you guys somewhere. Oh yeah, there it is. Okay, way back here as well. So in this case, we're able to say, you know what, even though we think a lot of your seizures are coming from the left posterior, you clearly have other areas in your brain seizures are coming from. So even if we did surgery, it would not likely make you seizure free. And this is not probably then a great thing to wade into, and maybe you should look at other options and keep surgery maybe as a maybe towards the no side, and not like, oh yeah, you should go, you're kind of a slam dunk, you should do well with this, and think about it. So it kind of helps us with making that decision along with all the other data that we know about the patient. All right, what about the other aspect, which is how do we look at some of the functions of the brain that are important that we don't want to do surgery and interfere with? So I'm just going to show you a couple of these, how we can use it for mapping. So we can look at all these different areas that are important, and you can kind of see, oh, what happened? There we go. The color coding of these. So sensory motor, so how we feel, how we move an arm, our vision off to the side usually. Auditory is hearing, and then our ability to understand speech and to talk. And kind of color code these on the brain so you can see where these are. So how do we kind of get at finding those? So let's look at sensory and motor first. So one of the things we can do if we want to look at motor, and the hand is usually the easiest area to pick on, we can do it a couple of different ways. There's either a pneumatic device that you can just kind of squeeze the finger gently with, and if you time lock that to when the brain feels it, you can figure out where in the brain the part is that feels it, or you can do it with a mild electrical signal as well. So that either way, there we go. So it's placed on the hand while the patient's in Meg, and then you can see kind of we can record from both the right and the left side. So the right hand going to the left side of the brain, left hand going to the right side, and we can record where that is in the brain, so we can say, okay, where is that in relation to where we might operate as well. So let me just show you kind of an example of that. So this is someone that had focal cortical dysplasia, a very common cause of seizures that are not controlled with medicines and can be refractory. We looked at their epilepsy part, which is kind of the yellow triangles recorded from their Meg. They were all kind of sitting on top of that dysplasia, which you would expect. But the other thing that we saw is the hand was right there as well. So we knew that if we did surgery, yes, we would get rid of the seizure problem, but the person would lose their hand. And no one ever wants that trade-off or accepts it, I can tell you that. So we kind of had to say, okay, what are other options that we can do and help their seizures without getting in the hand area? The one on the right here is a little bit different. So this one you can see where hand is. This is a person I've kind of outlined. They had a tumor here. that was causing their seizures. So in this case, we talked to our surgeon and said, you know what? Be very careful, but we think you can get this out and get rid of both the low-grade tumor and their seizures without affecting hand function, which is what they could do. So this was really helpful in knowing this in advance, and especially in planning and talking to the family. Let me give you a couple other ones. So this is a patient that had prior surgery. You can see where the surgery was, up here. We knew it was going to be close to motor areas. You see on this side where it was here. We did the dipoles. One of the things you can see is they're all on the front edge of where the prior surgery was. Luckily, they knew to be kind of up here and not back here, close to hand area. They were smart. So we could safely go in, but in this case it helped our surgeon because he knew to go in from the kind of the front side, if you will, stay away from the important hand area on the back side, and he could get rid of all the epilepsy part without getting into critical function for the hands. So even for folks that can have surgery, it can help you even plan like how do you approach that as well. All right, let's switch gears to language. Language is important in our society. If you have language problems, you're in trouble, right? So how do we do language tasks? So the way we typically do it is present words. You can see kind of a couple words here. You can simplify it. If you need to make it simpler words, this is just average. The patient's lying in the machine, and we just ask them when they hear keywords just to move their finger. They don't have to move their finger. We ask them to do that so they stay awake, because otherwise you're laying flat in the machine, you just nod off, and then we fall asleep. So it's just to make sure they're engaged and staying awake for us. And you can see we record kind of as the brain processes the language, and then we can put that on top of their brain MRIs for them hearing language. I'll show you slightly different. So this shows our patient here. We're projecting words on the screen. They can read. This would be down around their head normally. And you can see that on the right that what happens normally since they're looking at words, in this case is the yellow is kind of your visual areas highlight first because you're seeing them. It often goes to kind of what we call basal temporal areas, so the orange area. And then it goes up to receptive and expressive, the red areas, as you try and kind of figure out those words as well. And we'll get to one other aspect of this in a minute that's interesting. You can do it in multiple languages, and we've nicely showed this. So in folks that are bilingual, this is in Spanish and English. So you can get different maps. You can map their Spanish and their English. Some of the maps will look different, as you see here, from 3 different folks, depending on when they learned those languages in life. So as you might guess, patient 3 learned learned English. Was a Spanish-speaking, learned English later in life. These patients that largely overlapped were their kids that grew up in Southern California knowing Spanish and English at the same time as well. And you can map other languages as well, which becomes important if you're dealing with other languages other than just English, obviously, because languages map very differently, especially if they're not of European ancestry. As you get into Asian languages, the maps are very different. As well. So you have to take that into account when you're looking at where folks localize language. So let me just give you a couple of examples of that. So this is, again, someone had a low-grade tumor. You can see its outline, and we looked at their language areas. It was just below it. So it's helpful for the surgeon to plan and know they could proceed with resection. This is for someone who'd had a prior stroke. And you can see their kind of epilepsy part, all was on the front edge of that. Their language, even though this is the left hemisphere, and most of us have language on our left hemisphere without knowing anything else, probably 90% of the population, that's where we have language. That's how we're just supposed to be. But this person, because of their early stroke, had shifted it, and you can see that most of their language was on the right, very little on the left, and the vast majority was here, which told us that yes, they could have surgery and not lose any language function. This is another one that's a bit trickier. This is a person that had onset of seizures. You can see a very small abnormality here that I've kind of have a pointer on for you. 2 different MRI images that was felt to be a low-grade tumor sitting right near where language areas should be. So if we look at MEG testing, sorry, you have to be really quick to get that one, huh? There we go. You can see that their receptive language in the green was right behind it. They're expressive in the red. So there was an option to do surgery on someone like this and still preserve language function. without affecting it. So it's helpful kind of putting this together to do that. The other thing that actually we've noticed over the years is that you can do almost all of these with someone totally asleep as well too, because one of the challenges, some of our patients, whether it was age, they couldn't cooperate for lying still, just cognitive challenges, they just had a hard time being still no matter what age they were, or just had a hard time being still in general, that we'd have to give kind of mild sedation so they'd be asleep during the test, that you can nicely record their dipoles for their epilepsy part, and we could do their sensory part by kind of squeezing their finger. The language was the one that we weren't so sure about, but as we did that, what we discovered is that many folks, even if they're lightly asleep, your brain is still processing language if you play it in little ear sets. Yeah, the brain, if you put words into it, it tries to process them because that's what the brain is supposed to do. It does what it's supposed to do. So it's not 100% of our folks, but for some folks this is really valuable because it allows us to get information that otherwise we just couldn't get as well. So it's nice to know that we need to. We can do this under sedation, and we've kind of developed kind of a light sedation protocol that allows us to have the best kind of yield for doing this. So let me just finish up by reminding you that MEG can be very helpful. It's a neat technology it's non-invasive, it's safe, it's not subjecting anyone to magnetic field or X-ray field. It's just recording their own natural activity. Very helpful in looking at epilepsy surgery patients, and especially if they have a brain lesional abnormality and epilepsy, so we can say where is the epilepsy part, where is the lesion, where is kind of normal functions we don't want to affect. And we can look at it to study brain function in real time. It's the only thing that allows us to track function in the brain in real time. So aside from epilepsy, that has been used, for example, to understand like what happens in children that have dyslexia. Because we can track language and actually look at this to say, oh, this is telling us how we need to treat those children, and that's been done. It's been looked in Parkinson's disease to look at motor function. So in other areas outside of epilepsy where you want to know about brain function, that's also important, but it's not the epilepsy side as well. So let me stop there. Appreciate everyone's attention. This is normally where I am when I'm not at Disneyland. And we have time for a few questions. Thank you.
Sorry, our microphone is out, so please go ahead.
How long does the test actually take?
Yeah, great question. So depends how much you're doing. So her question was, how long does the test take? So let's say you're doing, a lot of stuff. So you're trying to record the epilepsy part. Maybe you want to know about language. Maybe you want to know about sensory motor. Actual time in the machine, probably close to an hour. If you just want to know, say you just have a tumor and you just need to know, like, where is it? How close is it to language or motor areas? You could probably do that in 15 minutes. Yeah. Right.
The functional MRI, do you only do that when you're trying to figure out what to stay away from during the surgery, or do you do that by itself for various different cases?
Yeah, so let me make sure, I want to clarify one thing with your question too. So when we look at functions with MEG, it is different than functional MRI, which can look at function.
Right.
There are differences between the two technologies. They can be complementary because sometimes we find better data with one than the other. So there are some folks who actually do both because we need both of them as well. But to answer your question, there are some folks that we only need to know the functional aspects, yes. I mean, there's a lot of folks on the adult side that have a structural brain lesion and don't have epilepsy, so they have a brain tumor or something like that, a blood vessel abnormality where the surgeon says, I need to approach this, but I need to know how close it is to motor areas or language areas, and then they can just get that single test. And to be candid, those are the easier folks to do because the tests are simpler and shorter and it's much more straightforward. I don't know if was that your question?
Yeah, the MEG, so with the functional mapping with the MEG is, I guess, how is it different? Is it better than functional MRI?
So I would say they both are helpful. There are different times where they can be useful. So for example, if you have some brain tumors in adults are associated with changes in blood flow, and functional MRI is based on blood flow, so you may not be able to get functional MRI study in those patients, but that will not affect MEG, for example. If they can't cooperate for functional MRI testing awake, as I just showed you, you can do mega sleep, and there's a lot of folks that are too claustrophobic or just can't do functional MRI awake. So that's why I said they can be complementary. Some you kind of pick and choose based on the patients, and sometimes you do both just to validate that, okay, we're 100% sure this is where this is. Yeah. Let me go here and I'll come over to you. Go ahead.
What a powerful tool, but I understand in the United States there's a limited number of centers that have the MEG. And I think in California, there's one, functioning two.
Yes. There's two. They've doubled since we were here.
There's two and there's going to be, as I understand it, two more.
Yeah, there is a limited number. You're correct. So if we look at technology globally, I mean that's why we all do MRIs for structural, because there's MRIs everywhere. Now they may be different quality, but they're everywhere. To set up and run MEG lab is not everybody has. It's expanding in the U.S. compared to what it was when I first started with this technology many years ago. But where we need to be? No, sure. We need more facilities that are capable of doing this kind of studies. Here, yeah. Go ahead, let me hear.
My question is, if you get a new patient that kind of building on what Margaret was saying, like that has epilepsy that you're going to be looking at for, from the epilepsy standpoint, but they also they need a functional MRI because they have, learning disabilities as a result, would you then determine when the patient goes in for the test whether you want to do both or not, or how to?
Yeah, I mean, one of the easy determinants, at least in our center, is if they can't do an awake, MRI or MEG. In other words, they need sedation to be still for 45 minutes or an hour, because we see a lot of children, even some adults, that can't do that. So if they can't have a functional MRI, basically. So that's an easy one to say, okay, that divides the two groups, right? Pretty simply. And then some of the rest depends on kind of what you're looking for, because there are some subtle differences in functions that they both are able to test for and that they do better with. But the easy one is just, can they even do it? Because there's a lot of folks that have a really hard time just being awake in an MRI machine for an hour and not moving. Yeah, go ahead.
Does VNS, can you do this?
Yes. So with the current equipment, a great question. Her question is about VNS, but I guess we can make it more global to devices generally, since so many people have devices nowadays of all sorts. With earlier machines, we had a lot of artifact from anything metal, because that also creates a magnetic field. So even prominent fillings, other things. With the current equipment, we have the ability to filter out a lot of that kind of extra, environmental, I would call magnetic noise. So most of the patients we can do, if we don't know 100% for sure, there's ways to bring them down and kind of say, okay, are you creating enough noise? We're going to have a problem, without kind of going through the whole test, if you will, and sedating or not sedating. But with many devices nowadays, we can, yeah. In VNS, we certainly can.
So you're saying you can do with some devices. Is that the same with if you have a titanium plate and titanium screws?
Yeah,
Does
so
that get in the way?
yeah, so once you get devices in your head, it's a little bit more of a challenge. So yeah, if you have a titanium plate in your head, titanium screws from before, then that's probably going to be a challenge as well. Some folks with a shunt, some of those folks, it's not a problem. Some it is, depending if it's the type of shunt it is. Many of those we can still do.
Yeah, so what if the plate's in like the left temporal lobe and the screws?
Yeah.
Around this area.
Yeah, if you've got a metal plate in your head, it's going to be problematic. Yeah, you're probably not going to be able to get a MEG study done. Yeah. Luckily, which is the reason, for many years now, luckily our surgeons are not using those as much as they used to many years ago. But there are some that have been there. I get that. Yeah.
Well, for those who can have it, you know how we were saying there's just two in California.
Right.
You know how it is with crazy insurance and a million different providers, etc. Do they ever transfer from wherever they're originally to this? Are they connect to?
Yeah. Your question about getting the test. So much like an MRI, I don't know if you've ever an MRI generates lots of pictures. You can put all those on disk. That can be given to you, brought to your facility, uploaded. MEG is the same way. I mean, we see patients from outside of our center pretty routinely that come. We load the study onto the disc. They can bring it back to the referring epilepsy team, their surgeon, just like the pictures I showed you. It's kind of color-coded, plus the report, so that they can upload it, and they'll see just like the pictures I showed you.
In reference to them reaching you to be able to get to
the MEG. Yeah, no, it's not a problem. I mean, most MEG centers are able to do that. Yeah.
They're able to take it
from other areas. Yeah. Yep. All right, maybe I have time for a couple more questions, one or two, I think, before we get kicked out of the room. Okay, go ahead.
So do you have to have an active seizure while kind of going through the study? Can you be on meds?
Yeah, great question. So the MEG is recording abnormalities kind of between seizures that we see. Now, if we got lucky, if you want to call it lucky or unlucky, however you want to call it, if the person was in the MEG and they happen to have a seizure, remember you have to be still. So some people, when their seizure starts, they may just freeze and kind of be out of it before they move. So if that happens and we happen to be in MEG, we'll record that onset. Now, once they move, it's like a moving, picture. You won't see anything, right? It'll just be a mess. But if they move from the get-go, then unfortunately we'll lose that. But most folks have a little bit of a change before they move. But again, 99% of the time or more, we're recording the changes between seizures. Most of our medications do not modify that in a way that would interfere with MEG, and actually, as odd as it sounds, some of our seizure medicines actually increase the abnormalities we see, even though we take and prevent seizures, that between seizures they actually increase the amount of abnormalities. So yeah, they tend not to have a negative effect. Yeah.
We have time for one more question.
All right, well, thank you for your interest. I appreciate it.